Hi, and welcome to the Hader Institute. My name's Helen, and I am your trainer for the Diploma of Mental Health. Welcome to the module tonight, and this is an induction to show you a little bit around Hader. First of all, we'll do an acknowledgement of country. So in the spirit of reconciliation, Hader Institute of Education acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We recognise Aboriginal and Torres Strait Islander people as the first inhabitants of this nation and the traditional custodians of the land on which we work, live and study. We express our gratitude for the sharing of this land, our sorrow for the personal, spiritual and cultural costs of that sharing, and hope that we may move forward together in harmony and the spirit of healing. We pay our respects to all First Nations people and acknowledge elders past, present and emerging. Now, this is what we call housekeeping. So when we're in class each week, we show these slides. So we ask that everybody has their cameras on and you can see that you're ready for learning. And please have your mics off whilst I'm presenting in class, please, unless we're doing ask questions section. To ask questions in class, you can use your hand emoji. It's in the reactions section, and you can put that up, and then once I'm presenting, I can then answer your questions. We have break times at 7 and 8 for 10 minutes, and sometimes we like to put them together and have a 20-minute block break in the middle of the session. We have respectful relationships in our classes where we're mindful of our words and our dialogue, because it's our duty of care in respectful language and leaving our biases aside. And that is also being aware that other learners, we're all in this together, and you'll need respectful languages out when you're out in the community working. No smoking or vaping on camera, please. You wouldn't be doing that in the industry, in live work. So treat the classroom like your live work, please. Trigger warning, sometimes there are contents that can have adverse reactions for you, and your learner portal has resources for support in those. And we always encourage you to make sure that you have time out for yourself each week. Make sure that you're ready for class, you're feeling fresh and rejuvenating your mind. So let's have a look at assessments. There are many different types of assessments, starting off with the quizzes, case studies, research projects, role plays, and practical assessments. Role plays will need to be done, some of the role plays need to be completed in front of an assessor and with other learners, and this will be organised throughout the year for you to book in a session. Other role plays can be done with family, peers and colleagues. So these are role plays that do not have a red heading, must be assessed in front of an assessor live. If you need help finding other participants, please let me know. So in your coursework placement component, this will be completed from about halfway through your studies on. If you've completed just over that halfway mark and you can show that you're service ready, and a suitable placement can start to be looked for. Don't forget, you can always access, if you're in a suitable workplace, to do your placement there. Or if you know of someone and you approach them and ask that organisation, that's great. Go out and seek out and do that yourselves as well. So with your assessments, you will be given approximately 48 hours during business hours. So that's our aim when we have a full complement of staff on board. So if an assessment's marked not as satisfactory, you will get adequate feedback from a marker to help guide you in your next attempt to complete that. Just remember, if you're doing a report or some sort of lengthy PowerPoint with lots of information, make sure that you do referencing. If you don't know how to do referencing, please ask your trainer and they'll be able to guide you. Extensions, if you need extra time, please reach out to your trainer or to an LSM trainer across the board. Life events happen, so we're flexible with that. So if you need help with any role plays or your assessment tasks, please book into what we call Calendly, and you'll have access to that through your learner portal. And here's the link here on the screen for you to access a trainer, and that's a 30-minute session available to help you unpack tasks and do role plays. And you can have one of those once a fortnight, so that's 2 a month, and you get 12 hours a year, so an hour a month. Rolling intake, the course at Hayter Institute of Education is designed that so you can come in and out quite quickly and start at the beginning of any new unit. So every time we start a new unit, we're all new in this together. So connecting with the learning support team. If you have issues with your Accelerate or ASEX, accessing your assessments, any IT issue that you might have getting into class or glitches throughout your system there to do with Accelerate and your assessments, please email the learning support team at lso@hayderinstitute.edu.au, and they'll aim to get back to you and support you through. Role plays and recordings can be put together by you as part of your task, and to assist you, we've made a role play video that's accessible through YouTube, and it describes what we're looking for as markers in your role play. We're not expecting great actors we're expecting to see you meet the criteria if you're talking the industry language and how you communicate. There's also an accompanying video for help you how to upload your videos and what style of video recording that it needs to be done for Hayter. So it can't be done on Movie Maker. It needs to be an MP4 format, or reach out to your trainer and ask more details. So we're here to support you with your studies, and it is a safe space, but some of the content can be triggering and confronting. So please ensure that you have your supports around you to reach out for somebody if you have an adverse reaction to any content. And in your handbook with your learner guide, there are not learner guide, in your handbook, in your learner portal, you'll have resources there for you to reach out for numbers that you can call, other than reaching out to friends and families as well. So let's normalize those feelings. It can be overwhelming. It can be stressful. It can be fun. You can be anxious. You can be ambitious. All of these things are a part of learning. And that's why it's called learning and not knowing yet, but you will. So please enjoy your learning. Thank you. So welcome everybody to provide services to people with coexisting mental health and alcohol and other drug issues. This is session 1 of 2. So to begin with, Tash, could you do the acknowledgement, please?
Yeah, in the spirit of reconciliation, Hayter Institute of Education acknowledges the traditional custodians of country throughout Australia and their connections to the land, sea, and community. We recognise Aboriginal and Torres Strait Islander people as the first inhabitants of this nation and the traditional custodians of the land on which we work, live, and study. We express our gratitude for the sharing of this land, our sorrow for the person personal, spiritual, and cultural costs of the sharing, and hope that we may move forward together in harmony and in the spirit of healing. We pay our respects to all First Nations people and acknowledge elders past, present, and emerging.
Thank you. So just remember around reaching out for resources for adverse reactions. We have 13 Yarn, Lifeline, and Beyond Blue, as well as Mental Health and Beyond Blue app. And there's many more in your learner handbook as well. So a bit of housekeeping, cameras on, mics off, and hand participation, break time 7 and 8 p.m. We might even do a 20-hour block, a 20-minute block in for tonight, small group in. And just remember, be kind to yourself throughout the week. Make sure you're looking after yourself. This weather is not being kind. So we're going to look tonight at substances, alcohol and other drugs, mental health and AOD, and the identification strategies for working with clients who are affected by alcohol and other drugs and other illnesses. So let's kick off this. Just a small video about an introduction into this unit. So I'm just going to press pause. Besides the plug for mental health social workers in this from the American clip, it was to actually talk about the point I wanted to bring up in using that was around the mention around the critical work environment that you can be working in at times, not all the time, but at times. And this is, you know, as it is, you can see it was American based, but there's a strict criteria very similar to Australia around accredited workers in organisations from government, working in government hospitals, especially when they've got those centres in there, which is very similar to the American setup. And just for knowledge here, the Australian Association of Social Workers have what we call mental health social workers, and they're accredited mental health workers who work side by side in the field with psychologists and psychiatrists. They can't implement medications or anything, but they can do all the counselling and referral processes for mental health. So what do you know are common types of legal substances that you can access freely? Do you know the name of them? I'll shoot one off. Coffee, caffeine. What else can we get over the counter, Adam?
Alcohol, cigarettes, pain
Definitely.
medication.
Yes, Valium.
Sorry,
Morphine.
what did I miss?
No worries. So what's the common types of illegal substances then?
You've got methamphetamines, MDMA. You've also got things like ketamine. You've
Fentanyl,
also got fentanyl,
heroin, cocaine.
Yeah.
Cannabis.
Welcome, Manic.
Thank you, Helen.
So, knowing that some of those legal and illegal substances here, What mental health disorders that require medication? Because not all illnesses, and I should say not the word disorder, illness requires medication.
Schizophrenia,
Mm-hmm.
that requires medication.
Yep.
And relating it back to drugs, anxiety. A lot of benzodiazepines are prescribed for people that have higher levels of unmanageable anxiety.
Very true. Yes. So we have schizophrenia, anxiety, along with anxiety, depression, bipolar.
Yeah.
BBD.
BPD is more of a trauma therapy based rather than medication.
Depends if it's type 1, type 2, though.
Yeah, that's true.
Okay. You got one, Adam?
No, that's okay. Yep.
Oh, right. All right. What do substances and AOD work in legal substances, as we pointed out? Why do we use these? Why are people using prescribed caffeine? Look, I noticed the other day that you can buy Panadol with caffeine boost in it. And because it's supposed to speed up the process of the pain management. But then you've got to be wary of people who have heart conditions and if you can't drink more coffee over the top of ingesting caffeine. So it's great warnings on it, but here it is, it's over the counter. I mean, we've really got to start looking at what we're taking for painkillers. So a lot of these will actually have a lot of effects, and depending on the substance around, it affects the alertness, the activeness, anxiety can relax you to the point where you're totally relaxed and feeling too tired to do anything. It can increase your heart rate as well. Depends on which one. The caffeine, Adam? Yeah. That actually, caffeine is also good for asthma attacks. When you've got that hacking cough, they're actually using that as well. Tash?
I just wanted to say that also on the screen before this one, a lot of medications have a lifespan. So, especially with AOD stuff, if someone's had a drug overdose on, say, Panadol or, we'll use Panadol for an example. Panadol has a lifespan of 4 to 6 hours, and usually they call it a half-life, which is where the effects start to wear off at around about halfway point.
Yep.
And so my point is that's the same with a lot of stronger base medications like endones and tramadols, and they all have a different lifespan. And depending on where you are in that time span will depend on how bad your overdose is, or how bad the client may be. You know, they might be drowsy, they might be incoherent.
Yeah, that's so you're saying half-life,
Yes.
is that? Yeah, okay, cool. Thank you for that. Right. So let's have a look at some of the other illegal substances: cannabis, inhalants, methadone, GHB, hallucinogens, marijuana, ecstasy, but medications not meant for the use of for certain individuals, or can which are used incorrectly, start with Valium, codeine, morphine, oxycodone, diazepam, and fentanyl. And these can produce effects depending on the substance, as we said, especially around your alertness and increased heart. So substances and AOG, harms and impacts of long-term use. The drug tolerance that you can build up in your body takes a long time. The addiction part can happen quite quickly. The tolerance can build up, and then that aggravates the addiction. So the body gets used to the drug, taking more to get the effects, and then that's when sometimes it can lead to an overdose because they've taken too much to try and get the hit. Especially if the person hasn't used it for some time and then goes back to it and then takes a higher dose than what they were using before. So with the withdrawal is when a person stops taking addictive substances, and then for some, going cold turkey is a huge way of coming down, and it's really racks the body and the senses for at least 48 hours or more. And this is where you can have the shakes, hallucinations. You can be confused, you're sweating, you can be moody, fluctuations in your temperatures, your stomach can feel quite sick, really grasping pains across your body as well. Sleep disturbances, yes, dry reaching a lot as well. And when they talk about people who have a dependency, it's classed as when people can find it very hard to stop taking substances. And those then have different symptoms again around the mood swings, the aggression, the tiredness, the depression, often isolating themselves, doing risky behaviors. And this is where the more unintentional adverse effects happen around moving in towards crime, aggressive relationships, losing employment, finances. All these things affect the body physically because of the weight, can go up and down, cravings, poor personal hygiene. One thing dominoes onto the next. Gabrielle Archer, you have studied alcohol and other drugs.
Yeah, I have. Hi. Um, I have.
So what is the main thing they're talking around? The dependency. What are some of the behaviors that they would identify with that?
Behaviors of dependency, like such as mood and behavior, sort of affects to changes in behavior.
Mhm.
Yeah, and physical effects.
And they're the most
So,
noticeable things, aren't they?
yeah, physical, yeah. Even such things as malnutrition with dental work. So,
Yep.
things like that. Yeah, and as the tolerance goes on, you find that they may seem to be going elsewhere, especially if they need a dealer or something like that. So they're going places and you don't know where they're going.
Yeah. Thank you.
They're very secretive. Yeah.
Yes. Right. We're going to just do a little bit of group work here, in that you're going to identify, research an illegal or legal substance, identify the long-term effects, and what does it do to the body. So I'm just going to stop share. Welcome, Wayne and Gabby. Sagar.
Thanks, Helen. Sorry if I'm a little bit nasally. I've got some kind of bug.
Not too well, hey?
Oh no, I just but I mean I've got Wayno here who's like treating me like a queen.
Not a
All
queen.
right. So
Yeah. So if I can't talk well.
I'm taking care of the Cheryl.
Yeah, if I can't talk well, that's just the throat. It's like burning like acid.
oh,
Horrible.
okay. Well, we won't get you to talk too much, okay?
Okay,
So
all right.
room 1, Mihak and Tash. Room 2, Adam and Gabby and Wayne. Right. Research one legal or illegal substance. What does it do to the body? What are the effects? What is the actual substance? And how harmful is it? So,
That's so funny.
all right. Mihak and Tash, what did you research? Legal or illegal drug?
Miha, did you want to talk or did you want me to?
That's all good. So basically what happened with our group is Tash had a lot of information about legal drugs and I was really open to learning from her. So she kind of just taught me about opioids and benzodiazepines. Yeah. Tash, if you want to take over, that's all good.
Okay. So you're in the wrong one. It's in the legal, not illegal. Yeah.
I suppose it depends on where you buy it, isn't it?
Oh, yeah. Well, I didn't go that far. I just went by what I know from like knowledge, really. But yeah, you've also got. I explained to. Sorry. I explained to Mihak that a lot of the time people with opiate addictions that started with things like endone, Candine Fort, tramadol, those sort of medications will eventually, their tolerance will gradually get higher and higher, and their need for medications will get higher and higher, and then that's how it can then link into illegal substances like heroin, because they can't access the medication that they need to get the high that they're after. So the next best thing if you can't get your morphine or your fentanyl or all those hospital-based sort of medications, some people go to the illegal path and then go get onto the heroin and then find that they have to use something like methadone or Suboxone to get off the meth or heroin. So it's sort of a double-ended sword.
Yeah. What did you have a look at what some of the effects are on the body physically at all?
So, with the diazepam and the opiates, they both can cause liver and kidney issues. Opiates can cause severe constipation. Diazepam can cause confusion, hallucinations, irregular sleep patterns. Opiates can cause like distorted taste,
Yeah.
like things taste differently. But I didn't need to research this because I researched it for my research report.
Excellent. So, distorted taste, sleep patterns, hallucinations. I think I missed some there.
And body aches.
All right.
Body aches are apparently atrocious.
Okay. Well, it's handy certain that you were doing your
My
research
assessment.
earlier,
Yeah.
wasn't it? Yeah. All right. Thank you. Adam, Gabby, and Wayne. What did you research?
We're kind of like in between our lovely reunion. We managed to do some work.
A lot of time was lost during reunion with Adam, so far
Well,
as talking time.
Yeah.
But what we mainly concentrated on was marijuana and hashish.
Yeah.
Now, the problems with hashish can be that the person, if they've been continuating for a long time, they don't want to stop because being on hash pushes the part of the brain which takes the lead,
The tolerance.
which takes the lead with people,
Yeah.
where you've got a person who is on top of everything, or it appears to be that way. They come out with incredible society problems that can be solved, because they have a tendency to simplify everything.
And then we covered the withdrawal.
Yeah, well, the withdrawal from hash is much the same as withdrawal from heavy marijuana smoking, and that is that they can be, well, let me say, stoned for up to 6 to 8 weeks.
So what did we mention? We mentioned
The problems of getting a hash person who's been on hash for a long time, the walking can
that's what
sometimes
comes to the
go.
gate. Yeah.
The actual gait can go. They don't want to give it up because they miss what they're like and the character that they are when they're on hash. A doctor, this is one thing I didn't mention, a person going to see a doctor who knows about hash, even without being told, will look at the person and say, how many years have you been smoking hash?
Wow.
Yeah. Wow.
Yeah.
And that's a fact.
Yeah.
I hope we've given you enough.
Yeah, I didn't know about the walking, the gait.
Yeah, me either. I didn't know that either.
So
That's
limbs
very
become
interesting.
wobbly. Wayne,
Uh,
limbs become wobbly.
Yeah, wobbly,
Um,
or is it?
yes, they become at the start of the morning
Yeah.
wobbly because the level of hash, you see, the actual smoking doesn't start until they've woken up and had coffee and something to eat, if they want something to eat. But hash people who've been doing hash for many years
Yeah.
don't want to walk around too much.
Yeah.
They like to lie about.
It's unsteady gait, you were saying.
Yeah,
Yeah.
the gait is also unsteady. Like sometimes you'd think of the bloke as being drunk or the woman as
Yeah.
being drunk. That it's stagger gait.
Yeah.
They walk all right, but they stop walking and realise they're not going where they want to go. And that can be a very disturbing factor.
That would look disturbing, I reckon, to an observer.
Mm.
Mhm.
But
Yeah.
that's long-term smoking.
Yes.
Yeah.
I know that because I've known some people
Yeah.
who were exactly there for many years.
Yeah.
Mm.
Like I know of two people who gave
Yeah.
up heroin up in a very tall tower building, and they gave it up.
Mm.
Wow.
Yeah, wow.
Takes some
Yeah.
strength, that does.
Yeah.
Mm.
Thank you.
I hope I've given you
Good
enough.
work, everyone.
Yep.
I did. I didn't know about that actually. Like it is now you say it, you see them walking with that gait, but it actually affects
Yeah.
the brain that affects the control of the muscles for the
Yeah.
limbs to be
Yeah.
able and then cause that gait.
Yeah.
Um,
That's right.
yeah. See, there's always something to learn. Tash?
Yeah.
I just had a quick question with the that what you guys were referring to, the wobbliness, the gated walking or whatever you were referring to. Could that be also an indication of an inner ear issue with balance?
Oh, it'd be more likely to do with the drugs if they're on that than
It's caused
unless
by
they're
many.
suffering from an ear infection, of course.
Mm.
Oh,
No,
okay,
it's caused. Sorry about this, Helen, but it's caused for many years of smoking hash.
Mm.
Um, it's it's a permanent thing that they have to be treated for later, because you are right in a way, Helen. It has to do with the amount of hashes that they're having,
Yep.
and it also has to do with in the stages of not being able to get hash,
Yeah.
there are changes in the body automatically. You are right, it's to do with the brain.
Yeah.
So let me tell you quickly. Right. Even though cannabinoid receptors are located in the movement brain region, which is in the cerebral cortex and the cerebellum, that chronic cannabis use, hashish, is used is associated with structural and functional brain changes and the long-term use of human movement. And what they discovered was it can cause a defect in the brain receptors and on the control and the velocity of the muscle movement of the knee and the elbow area. Hence, you get a walking gait because the joint has been affected. It's not so much the muscle part, they're talking about the joint itself is affected from the brain's telling the messages what the joint to do. So the knee goes, the elbow goes, so you often get that imbalance trying to pick up that wobbly. But with the walk, it's a neurological parameter that affects the knee. And it is all to do with biomechanics and what they call a gait analysis and the heavy use and ongoing of drugs. There's also parts of the ankle that can be affected well, but it says more greatly affecting the knee and the elbows. So hence you lose the strength in the arm, you lose the strength in the legs. And hence then becomes what they call an altered gait. Because you have a normal gait of how you walk, but it becomes an altered gait. So very scientific, Wayne, tonight. Thanks for bringing that up because that's a really important part because like you say, people might look at that and think that that person's actually intoxicated, but they're not. So this is where we'd have to be careful around assumptions in working in AOD, of course, because some of those patterns and behaviors are similar to other types of intoxication, but it's that long-term wearing off and what's happened to the wearing off of those joints and the mechanics. Right. It's just a 3-minute video. It introduces the individuals taking medication and taking alcohol with it as well. So I'm just going to press pause here. So the statement that was made was from that video, and I hope people at home make sure that you watch that video. The link will be in the recording. See the person as a whole, then identify alcohol and other drugs or mental health illness, treat those differently. So what I want to ask you, we'll go back to those groups that you were in, take this up the next notch with the research. What happens when you mix alcohol and medication? So I want to know the physical aspects and then what does it do to your brain as well? So you're going to have to do 2 different research questions here. What happens when you mix alcohol and medication? How does alcohol and medication affect your brain? All right. Let me just press pause. So we're going to do okay. So let's hear from Mihak.
So according to a bit of research, me, Teddy, and Biva, we found out that most common effect is usually liver damage. And some other ones were heart problems, Oh wait, we have heart problems. Internal bleeding. It also made you more likely to overdose on your medicines. I guess sometimes giving you like memory problems, you might not know whether you've taken your medication or not. So you're, mixing
Can happen.
things together. Yeah, so stomach bleeding, ulcers, and rapid heartbeat. And something that Biva also said was it could reduce the effectiveness of the medicine you're taking as well when you're mixing the alcohol. And Teddy mentioned that sometimes it can also affect your concentration and ability to regulate your behavior.
Mm. Oh, I'm just going to get up. Concentration and
Ability to regulate behavior. So giving you mood swings or, worsening your mental health as well, if you're taking it for your mental health.
right.
Yep, so that's mostly what we found out through our research.
Excellent. Thank you. That is a lot, isn't it? Like, it just goes on, doesn't it? And then I'd imagine if somebody's got comorbidities with that, if they've got just that per se asthma or diabetes or already have a liver issue or a kidney, yes, how much that affects that again. Gosh, thank you. All righty, let's hear from Beaver. You made it into the team. Were you with Beaver Mihak?
Yep,
Yeah.
I was.
Yeah, okay, excellent. Okay, who was in the other team? It was Gabby,
Gabby, me,
Sash,
Adam, Wayne, Sagar.
okay. Who's going to speak for that group?
Gabby can if she wants.
Okay, so when the alcohol is combined with certain drugs such as sorry, opioids, and alcohol,
Yeah,
such as opioids and benzodiazepines, it can increase the risk of respiratory depression and overdose, impaired judgment and decision making with mixing drugs and alcohol can impair cognitive and cognitive function, and may lead to risky behaviors and accidents.
I also found that
so hang on a sec. Tash. Sorry. Impaired cognitive functioning and what else was that, Gabby?
The cognitive functioning and it may lead to risky behaviors.
Right.
Yeah.
Yeah. Tash?
sorry. This is a little bit technical, but mixing alcohol with benzodiazepines actually affects the GABA receptors in our bodies, and it targets the benzodiazepines, barbiturates, neurosteroidals, and volatile intravenous anesthetics. These drugs can enhance these receptors functions to cause anesthesia, sedation, hypnosis, and I can't pronounce that last word, so I'm not even going to try.
So it's like an anesthetic effect, is it?
Yeah, so it affects a certain chemical imbalance in the brain.
Yeah.
It's called the GABB.
I call it
Uh,
GABA.
Yeah, GABA, GABA with a small a. So
Yeah.
it's capitals GABA and then a small a.
Mm. Because sometimes they do actually have GABA tablets in during detoxification, but it's still not really known whether it's effective or not.
Yeah.
It's sort of still in the research stage.
Well,
Yeah.
I know that they're researching ketamine for depression at the moment.
Yeah, ketamine and which I really
Sorry, we're losing you there, Gabby.
don't agree with because there's also research PTSD. They're using magic mushroom.
Yes, $15,000 for I think it's a 3-day stay.
Yep. Yep.
Hey.
Isn't that in Sydney?
One's in Sydney. There's another in, I think it's Western Australia.
Yeah.
Yeah. Yeah.
So imagine over 3 days
Yeah.
going through these withdrawals from this affecting the body.
Mm.
Oh, just horrific. And
And
it
like I
certainly
said, sorry.
needs to be a real supportive environment and a lot of medical things on board as well, to ensure the safety of this as well.
Yeah.
Yeah, Tash?
Sorry, I didn't want to jump in. Like in the breakout room before, not this one, but the one beforehand, like I was saying to me, had a lot of people when they're coming off, say for an example, heroin or ice, their bodies are in that much pain and physical withdrawals that it's not actually the drug itself that is making them like having the cravings. It's that they're wanting to get rid of the physical pain that their body is going through. So that's why they end up relapsing and having another dose because they can't handle the shakes, the rapid heart rate, the aches and pains, all that sort of stuff associated with withdrawals. And I've heard that coming off alcohol, especially if you've been an alcoholic for quite a number of years, it can have a very similar effect. The physical aches and pains are just apparently like through the roof.
And that's also due to the abrupt stopping of that as well. So you're breaking that cycle, that pattern of what the body was getting used to, and putting a block right up against it. So insomnia, vomiting, muscle pain, sweating, anxiety, insomnia, all those things come into that play, and then continue on. And that paranoia can actually develop as well. Tremors, seizures in some worse states as well. That whole disorientation, which I think we mentioned before as well. Wow, the people that work in these areas are doing amazing work to help people come through these periods of time when they want to make change. So thinking about that, thinking about the work that's happening there, how can you ensure your safety in all this as well? And that's certainly around making sure that you follow the organisational procedures around safety, because it is a risky environment as well, risky for the client, risky for everybody else. But as long as you're following those processes, because you're trying to help people through some of the worst periods of their time, of their lives here.
Can I
So,
just say something, Helen?
yeah,
So yeah, it's also, I mean, this is what I found with myself, that people can have low thresholds to drugs or even to alcohol as well. And so, I think as a worker to monitor, how much of a threshold they have, so I mean, like, for example, I had, I think it was just a little bit of vodka. And then I took 2 sleeping tablets, and it took 8 people, 8 nurses to get me upstairs, and that was just 2, benzos and a little bit of alcohol. And so it wouldn't have affected some, but because I had a low threshold, it
threshold.
really affected me, yeah. And it's a little bit like I'll never forget it. And this is really I don't know if anyone's heard about the Karen Ann Quinlan story, where she, this is where they found out that Valium is serious as far as mixing with alcohol. So she'd only had a Valium, a diazepam, and then she had one, what do they call it, pint of beers, um, only one. Everyone thought she was drunk, but that effect turned out to be where she was actually comatose. So no one can understand about the thresholds of if you're low or high. I think as
Yeah,
workers, it's really important to wonder how high.
understand that part of it. Yeah,
Yeah,
definitely,
yeah.
for sure. And was that the woman that fell from the cruise ship one?
I hadn't heard of that one.
No, no.
Karen and
Because they were
Quinlan.
saying that there was right. So it certainly identifies major issues, but like you say, identifying that person's threshold as well will be
Yeah,
how you're going to support them differently as well around
yeah.
what's needed as an intervention. Yeah, for
Yeah.
sure. Okay, let's leave it here for now. We'll go and have a break. All right. Welcome back, everyone. We're going to be looking at a video on remote AOD work in Northern Territory. So it should be quite interesting.
Is, make them a bit of understanding.
I just wanted to share that as a different view on working in the industry as well, and seeing an overview of what's happening on the ground, the important work that's out there being done. Right. Let's have a look at the risks here involved in mental health and AOD. So the risks of the medications combined with substances, and we were talking about that before around the different behavioural patterns on the body and what the effects were. And that organ failure, we talked about the psychotic behaviours, with prescribed antidepressant medication combined with a stimulant, such as it could be cocaine, and it may cause a risk of high blood pressure, increased heart rate, headaches, brain hemorrhaging. Marijuana can increase the effectiveness of prescribed antipsychotic medication. So this is when people can actually have a psychosis episode, low blood pressure, be disorientated, and the benzodiazepines combined with smoking tobacco increase the effects of the antipsychotic medication that somebody might be on. So huge swings of behavior that would be hard to manage. And lithium with caffeine can dehydrate the body and affect the lithium level. So then the reason of taking the lithium is then the benefits taken away. So one thing is affecting another. And you're talking caffeine here that, that people often, we use every day. Yes, Tash?
One thing that GPs have to be mindful of is serotonin syndrome. Have you heard of that?
No.
Serotonin syndrome. So we all naturally produce our own levels of serotonin in our bodies.
Yep.
Antidepressants, SSRI medications, those two types of medications increase your serotonin levels. And so they say to not have more than 2 SSRIs, because if you have more than 2 types of SSRIs, you can actually get serotonin syndrome, and it's actually quite lethal. Like, you could die from that. And so, for an example, if you are on an antidepressant and you're on an opiate like tramadol, which is an SSRI, and then they put you on a mood stabilizer like lithium, that 3 concoction, if your body has too much serotonin in it, you can actually go into a seizure. And so that's why some doctors are reluctant to give out antidepressants or too many types of antidepressants. And that's just one other side effect of medication mixture that I just thought I'd throw in there.
Yeah. So I'm just looking at it here, and the insomnia, the tremors, the diarrhea, the hyperreflexia, that's the increased reflexes happening and shaking, agitation, sweating, restlessness, rhythm muscle spasm, so you're not being able to control your muscles, side to side eye movement. You can't control the muscles around the eyes. It's called ocular clonus. And
I only know of it because they thought I had it once in 2013, and they gave me a spinal tap, like a lumbar punch for it. And geez, that was painful.
Yeah. So the confusion, the serotonin syndrome, are different to the ones that happen with anxiety as well. And often severe cases can actually be affected by the common flu.
Yeah.
and it can give off different symptoms. And then if you have caffeine with it, the serotonin, and for people with psychiatric illnesses, the caffeine can waver that up so high that having 1 cup of coffee can actually change that. And they're talking that most people can have brain damage from this, but they can recover. And it's a very long time. And it's also looking at the lowest effect dose of serotonin to recover this back as well. But it's a very long, slow treatment as well. So.
Sorry, I just thought I'd mention that, that's all.
Oh, it's interesting. Tash is very interesting. Learning so much. This is not a sector that I've done a lot of work in. I've worked with people who have AOD and addictions with mental health, but not directly in the AOD field. And how much alcohol and other drugs, along with coexisting mental illness, affects homelessness and isolation, poverty, and medical illness. So the vulnerability that their bodies come under, and the common flu, anything that's going around, it's very hard to be even immunized against. They're even talking about that the cold and flu shots will often not have much benefit at all for somebody who's taking drugs and drinking alcohol at the same time. And the dual diagnosis then becomes complex with other diagnoses that are happening. And it's often hard to diagnose somebody in that situation with a mental illness as well. And this is what we came across with when I worked in women's health. We had a multi-purpose women's health centre, so it treated lots of different areas around women's health. And drug and alcohol use together, domestic and family violence, homelessness, not able to secure a job for too long, maintain that job. They were the main 3 things that were so identifiable in the service. And cause severe dysfunctional behaviors, which then alienated them away from other services. And relying on medication and then having life events that are traumatic compound this again. And it's true what that young worker said before: see the person as a whole, then see the AOD or the mental illness separate. Because there's many other complexities that can happen. Yeah. And then that person can be layered up with extreme mood swings. They might have financial issues. All these things start to pack up and cause this complexity around this person. So for service provision in the industry, around your medical clinics, hospitals, screening, needle exchange programs, rehabilitation, detoxification centers. There's mentoring programs in the industry as well, and there's very specific programs around when you're leaving care and when you're that relapse prevention program. And there's often centers that offer residential crisis intervention, and there's also legal aid and community legal services that can support people who have been affected by this and who have had financial or legal issues along the way. So how do we do harm minimization as a worker in the industry? And strategies need to be put in place to reduce that risk of harm to clients coming in who are struggling with their mental health. And with that complexity of AOD issues, it certainly starts impacting on the service and how much is needed of a service to support one person. Gabby?
I just have to say about harm minimization. I don't know. I happened to, just go to one of the public toilets one day, and just recently, and I'm just reading on the toilet door saying, if you are using, just let us know. And let us know beforehand. Let a friend know, or something like that. And I thought that was a really good way of getting it out of harm minimization, is to let someone know that you're going to use and things like that.
Yeah.
Put it on, where people are going to see that sign.
Try and do, yeah.
Yeah,
Try
I
and
thought it
do
was
it in
really
a
good.
safer way, Gabby. Is that what you're saying?
Yeah. So if you're going to do it, don't judge them, but at least tell them that, I'm going to go and do this. So
Yeah.
that person can look out for you, or someone can look out for you.
And this is where the safe injecting rooms come in, isn't it?
Yep, that's right. Yeah, because rather than making it a criminal, like criminalizing it, we all know that people are going to use, it's like telling your child, no lollies before dinner, so of course they're going to want lollies first, you know what I mean? So it's a little bit like, we know that's going to happen. Drugs and drug use is going to happen. And so we need to, think, well, okay, what do we do to minimize the dangerous and severity, uh, and overdoses where we don't have any, things like that.
Yeah.
Yeah. Mm.
So, and I think what I heard you talking to is about workers providing that non-judgmental service to
Definitely, yeah,
people.
because if you don't, if you go with a judgmental attitude, it doesn't help. This is my personal experience. You know, um, half a year ago, I had these homeless guys saying, "When are you gonna be an alcohol and drug counselor?" And I was absolutely shocked. And I said, "Oh, I'm still studying and everything, but I'm getting there." And I said, "Why do you ask?" It's just as a matter of interest. And they said, "Because you listen." And that kind of just really shocked me. And, they were saying that their AOD counselors didn't listen.
Yeah.
Yeah, and, sort of, they were saying, "We'd prefer you, Gabby, as our AOD counselor." And that really shocked me, and I was mentioning about empathy, and it was really sad that they were saying that their AOD counselors don't have the
Yeah.
empathy and don't have the time to even listen to them, as a
Mm.
person. So it's kind of, that did really
So it's an
shock
important
me.
skill to have,
Yeah,
certainly.
Yeah.
part of your practices, your strategies on how you're
Yeah.
respecting the client
Yeah.
and
Yeah.
how you're working, or I'd put that together with a
Mm.
rights-based practice here around
That's right.
that collaboration that you're doing with
Yeah.
them to ensure
Yeah.
that they're
Yeah.
involved in their care, but
Mm.
knowing that they're not going to be judged and be able to not be stigmatized and
Yep.
retain their dignity
Yep.
in
That's
this,
right.
because dignity can be lost.
Mm.
And then amongst all of that is that dignity of risk, of choice, isn't it? To use,
Mm.
and like you were saying, that safe using, speak it out, share that so you can do that safely in that space.
Mm.
And I think only knowing a small part of that was seeing somebody who actually did speak up and did use it in a safer way. And
Yeah.
when there was a time where somebody didn't, the difference in that support for that person
Mm.
and what happened to the person who didn't do it in a safe way
Mm.
and the effects that kept going on. It becomes very, very evident what goes on. Tash?
Mm.
You were just about to mention what I was about to touch on, just in regards to the safety injection sites.
Mhm.
I'm like all pro for them. Like if it keeps people off the streets doing it, by all means do it. But I just believe, like, I was waiting at my doctor's clinic a couple of weeks ago, and there was a lady on TV on the news. She was kicking up a massive fuss about one of the injection sites I think it was in St Kilda in Melbourne, and she was saying that it was right next to a school, like a primary school, I'm pretty sure it was a primary school. And she was like going on about the safety of the children and all of that. And I could kind of see both aspects where she was coming from, in the sense of, having needles around, having drug affected people around young children probably isn't the best idea. But they do need to really consider the locations of where they put those injecting sites.
Yes,
Because
and it also depends on what security is with those sites as well and how well they're
exactly,
managed. It goes
and
with that too.
I think that's where that lady on the TV was going. She
Yeah,
wasn't
yeah.
against injection sites. It was just the fact that it was I think it was like 75 meters away from the front door of the school.
Right, yeah.
So it
So,
was in real close proximity.
and it's once again, what I know about centres, it certainly comes down to the management, down to the commitment of the community around that as well. Um, and that the ownership of that and the value of what that service does, it can be conflicting with other community views for sure. Thanks, Tash. So let's
No
have a
problem.
look at recovery and recovery orientated practice here. So does anybody know what recovery orientated practice actually means? So this is where the participant directs their own recovery journey. It's about valuing the lived experience of those living with mental illnesses and other health issues, values the needs of the person, and treats each person as unique. It focuses on the emotional and social well-being as well. This is where your person-centered practice and strength-based approaches, excuse me, come in here. And that is there to try and encourage other relationship and family support, decision-making. So often as a family group deciding where that recovery process is going, how is it going to be orientated and moved through? What's the journey going to look like? How can you build that person's autonomy to do this with helping build agency with the support of an organisation? So to identify these skills for you as a worker. When we talk about empowerment and disempowerment, this often looks at the empowerment of the decision-making part and the decision around the recovery, the type of treatment that you're going to use, and being able to access accurate information and services that are proactive in their support. And it often leads to helping increase that person's self-esteem as well. So their confidence is building and that motivation then can come about it. And then they can start to set and achieve their goals. And it allows clients to exercise their human rights of choice here. And that disempowerment is where that power, that control, that agency is removed, coming in and taking over somebody's mental health. They're not giving the existing autonomy in regards to being able to self-direct that and manage that, their own treatment and their recovery choices, and who will support them. It's really important to help encourage that focus on identifying that they're a part, that person is a part of that process. They own that process. We're supporting them with information and guidance and knowledge and resources. And it's also about the terminology that we use here too. Recovery is different to recovering. And recovery is about the sinking of everything around that person, their environment, their people, their culture, their relationships, their beliefs. All these things sink in together to help build that self-determination in somebody. Because if we work from an equity platform here, we want to make sure that everybody has an equal access to services and supports to meet their individual needs. So we can then help them have that recovery process. And that's a part of our role, in that we can help them attain that, collaborate with them, but get them to lead the way and verbalize what they would like to happen as well. So identifying the types of strategies and evidence-based practices that we're going to use here, it's around the participant to be able to make their own choices about their care and their health, the right to take risks in making decisions. You know, they're going to have different life experiences that they're going to learn from. We can learn from mistakes. We can learn from decisions that we've made, but that's a part of all of dignity of risk. And our evidence-based practice that we can take on board so we have the best knowledge and understanding where that comes from and what the objective is of that evidence can help our practices. There's also a national framework around practice standards for mental health workforce. And that outlines the skills, values, and knowledge and attitudes required of people to be working in the sector. So there are actually 13 standards in that national workforce approach, and they're looking for consistency across the board. This is where differences of understanding of what the processes are in each organisation. This is where you might have differences in organisations, how they use the treatment and the recovery process and how they feel they meet the standards of care and support. If we can do a consistent approach and maintain that across the board, valuing the skills, the knowledge that we can gain from interactions, research, study, experiences, we can then help keep that standard to a level that many more people benefit from. All right. Can we brainstorm, think of suitable relapse prevention strategies? What would you see as a relapse prevention strategy? What could you name? What would you like to work in? That would be interesting. Any ideas?
I think it's important not to, sorry, I think it's important to decriminalize and not to see it as a criminal thing, because addiction is just like you go break your arm, you get it fixed. So it's like if you're struggling with addiction, you should be treated that way. But I mean, I don't agree with people who actually deal with that. I think that that is a little bit different, because
Yeah.
they are gaining the money from that person,
Yeah.
but it's a person with an addiction. Yeah.
Yeah. Yeah. But then that leads to other issues then too, doesn't it? To what level do you decriminalize that? Yeah, and which drugs are you going to decriminalize? So it's certainly interesting to think that what that would be. Sorry, Tash?
I think Adam just touched on what I was about to say. Having a plan primarily set by the GP, like you can get a mental health plan, that can help. How you can get an AOD support worker through a mental health plan.
Yep.
So having access to an AOD officer, even if you have relapsed, is still better than having none at all.
Yep.
I think another program would be is it's very similar to what the movie 28 Days with Sandra Bullock, where she was offered a treatment facility,
Yeah,
or it was jail.
yeah.
So that is sort of giving the choice, of the person. Do they have a problem or do they not? I don't know. That might be a bit hard, but I thought that was a good, sort of way of going about it, giving someone a choice.
So if you're giving a choice, they're also giving a balance of here in that movie. It was the autonomy of making the choice to go for the treatment, or she had to then go with the legal system. So it's a bit of a balance of choice here, isn't it? And I think we, as Adam's touched on that RAP program, that was, I think we've actually brought that up in other
The RAP
other
program
classes.
is
And
actually a thing that they do a lot in mental health hospitals as a discharge plan.
yeah. So what are the signs of problematic AOD use? Let's have a look at that. Let me just press pause. So let's have a look at the assessment process that we can use in our practice. And using strategies like Adam's talked about, the Relapse Toolkit program, peer support to help along the way is crucial for that, helping build autonomy, dignity, and leading the way in their recovery and being able to build independence and autonomy and their own agency is really important here. So we're looking at coexisting conditions. How do they impact on the person themselves, the participant? How does that affect their social and financial status? How does that affect their relationships? How does that affect their communities? Are they isolated in those communities? Are they excluded because of social status? And we have heard a bit about that tonight around the needle exchange programs. Can that social and community status of something, actually their views, change how support happens? Does that then affect the financial status of that organisation then? Because if that financial status of the organisation is affected, then the support is affected. So if somebody's going through and trying to work through the recovery, the individual themselves, their financial status could be nil at the moment and relying on government support, but the unemployment that they might experience and the housing distress, they might have lost all of these. They could be in severe debt. And that is complexities laying up on top of trying to fight the dual coexisting alcohol and other drugs and mental illness. Are there charges pending for a lot of the people that we're working with? Is there a history of that? And how can that impact the recovery And then in the future, in securing employment and housing, there's a lot of work going on in the short-term and long-term housing area around trying to secure housing for people who do have a history of or criminal record that are proving and showing that they're making changes to be not so blacklisted, and to see that that change in the effort that they're making is their recovery. So treat them with dignity with that. Give them that chance to prove that. They've changed things, they've moved them around. Interesting to watch, some services do not give an inch and others are very flexible. So once again, our communities, our social organizations, social understanding of all this is very varied. Very varied. So how is the assessment of a person done in a way that can identify their goals and priorities for recovery? Gabby?
Yeah, I just want to go back a bit about the
Yep.
judgmental part. You know, and this happens a lot. Well, in Melbourne, I don't know, in other states, but often if you go into a detox or something, immediately straight away, you cannot go anywhere unless you've done a drug test. And, you know, I think that's really, I think to build the rapport, we need to give them the benefit of the doubt. You know, it's very to the client, it's very it's kind of like a judgmental that immediately you're judged. So you've got to go for a drug test. And if you don't go for it, then you don't get any assistance, you know, and you know, seriously, those tests can be so difficult for just, you know, because they're under a lot of stress and everything like that.
Yeah.
But yeah, once again, it's you know, especially if they go for legal, anything like that, still they can be very stressful testing.
Yeah,
Yeah.
definitely. Especially if they're
And I
dealing with
really,
that financial stratus, the
yep,
strain, lost their housing, lost their jobs, lost
yep,
family relationships,
yep,
and then the system that's supposed to hurt them, help them, make them feel judged in that
yep,
sense of
yep,
doing that as well. So that's
exactly.
why
Mm.
our work can be, if we're working in the industry, helping somebody make a plan for their
Oh,
recovery. But how do
Ella,
we identify? So sorry, Wayne.
um, I'd like to say that one of the first things we've got to get rid of is society culminating the problem back to the user.
mm,
Because I know a friend who gave up heroin because he wanted to work and he wanted to be a normal citizen like everybody else. Well, he gave up heroin and he went to um, Work Start, the program that the government's got um, for reworking again. Well, he got a job. Everything was all right for a while until certain people came back from holidays. And then he was shunned. In the end, I don't know how they got the information or who let the cat out of the bag, as it were. But they approached him and they said straight out, "You're a drug addict. What are you doing here?
That's terrible.
We don't want drug addicts like you turning up and working here."
Yeah.
Well, the position manager sacked him after listening to these people. And when he went for the dole, they told him that because he'd been sacked from the position, that the dole would not be available
Yeah.
for
That's
him.
terrible.
Now, he went back on smack. He
Um,
went back on heroin
because there's nothing else for him to
because
think.
there's nothing else for him to hold on to.
Yeah, I get it.
Howard.
Yeah.
Yeah. That's terrible.
Yeah. And this is the part of society that's that judgmental side and not willing to hear somebody's story. You know, that person had been clean for a long time. Yes, Tash?
I just wanted to say that I back in 2012 to 2014, I had 36 surgeries, and I was in the emergency department this one day, and the doctor was trying to put a cannula in my arm so they could draw bloods, and she was struggling, and she had seen, because I scar up really quickly and really easily, and I've got this one particular vein that they always used to go for all of my surgeries. And she put the tourniquet on my arm and went, "So how often do you inject heroin?" And I went, "Excuse me?" She goes, "The track marks on your arm." I said, "No, they're from all my surgeries." I couldn't believe it. I was like, if you can't find a vein, how do you think I'm going to? And then
And
I
it's
heard her nurse in charge walk past her. Her doctor in charge walked past her when she said that, and we never seen her again after that, thank goodness. But I was just a plain Joe Blow, you know,
yeah.
some random person in the emergency department, and I got
Yeah.
accused of being a heroin addict, and I was like,
Yeah.
how do you pull that out of your hat?
See, a little bit of knowledge used in the wrong way, and assumption and judgment.
Exactly.
They made an assumption. They had a bit of knowledge, but certainly did not even think about filtering that statement.
Because now I'm petrified. Every time I go to get blood work done anywhere, the first thing I say to them is, "It's all from my surgeries, I promise. I don't inject drugs." Like, it's just something I'm paranoid about now.
And that's a part of our society, isn't it? So, yes, it's really a timely reminder about us walking without our biases and judgments here. And if we can stick to our codes of practice here as well, because our practice frameworks are supposed to be a part of non-judgmental, leaving our biases aside, looking and following our legislative policies around support. It's about the rights and responsibilities of people that we have here that we're working with, not judging them or making assumptions or assuming that their life, because there's one thing that's happening to them, that there are generic things that are going on. I think our responsibilities, our rights and responsibilities, our work role boundaries, our, building that rapport with somebody, but still maintaining that client-worker relationship, all comes with ethics. And it doesn't say anywhere that we walk with bias and assumption. Because there's always the talk of the rights of the participant, the worker, the rights of the service provider, the responsibilities of each person. But how are we being responsible for things that we can't draw a line in the sand in? We have to understand that we don't walk that way around judgment and walking with our biases. How are we creating a safer environment for someone to be able to have recover in, or to seek out and say, I need help? So legal and ethical considerations around the workplace and an organisation, especially in an AOD service, also carries other responsibilities here around. We have to be careful for families of those coming in to use the service. We have to make sure that they're safe as well. So you've got workplace health and safety, policies and procedures in an organisation, but when their family and children are involved, that's another level of keeping them supervised if they're coming to visit somebody in a recovery centre. So think about that environment where you have to make sure that they can come to no harm or do no harm there. Is it the place to bring children to a recovery centre like that? What is the safety there for the child and for the person who's in recovery, the people the family members? Is it safe to do that? Is it upsetting? Is it going to cause imbalances? Is it going to enrich their lives and fulfill them and make them feel needed? Like, there's such a balance here that you have to consider, but we have to think of our legal and ethical practices here too around doing those sort of things in those centres as well. You can't, it's like being in a hospital going for a visit with someone. You can't let your children just run around anywhere and be at risk of harm. They could slip on something, bang into something. And this is another consideration that recovery services have to think about, is people who are visiting, family visits, how do they manage that? And how do you still maintain the client's rights around having that for them? Your duty of care, of course, is about minimising risks, working with the Human Rights Act of 1986, looking at those, making sure that you don't have any human violations happening here, equal treatment and support for all, making sure that there's no abuse in care for those who are in treatment, no discrimination, discriminating somebody to allow them to help them make decisions about their care. So if you can apply a non-discriminatory approach here, allowing people their own choices, culture choices, spiritual choices, the things that they want to try for recovery, and giving them equal access to service is really important. So the informed consent, we know what informed consent is, but how does that change when you're with and going through a recovery program? How are we still helping the participant be able to maintain the ownership of that recovery, plus us working with informed consent for them to be able to get more resources or different treatments? And don't forget, there's also mandatory treatment as well here. That then takes away that autonomy because it will be court ordered as well. And that can be a battle for many people coming into that as well. We also must remember to make sure that everything is around privacy and confidentiality. And if people have disclosed something, is that something that you need to report, or is that something that's just to be kept confidential for them? You know the distinction between what you have to report and what is confidential. And what do you need to record? Be careful of your wording, the way you record things, the written word. So, one last task really quickly. What is the name of the privacy and confidentiality and disclosure policy in your states that would support people in AOD treatment?
Sorry, can you say that again?
Can you research what policy or act would cover privacy, confidentiality, and disclosure in your state for AOD recovery? Can you do a quick research? Adam, I'll give you South Australia, since you're in somewhere in what? Whilst you're researching, I'll just talk about why it's important to have that privacy and confidentiality and disclosure guide for us as workers.
I've got one.
Yep.
For New South Wales, it's called the Privacy and Personal Information Protection Act 1998. It protects your privacy rights in New South Wales by making sure that your personal information is properly collected, stored, used and or released by New South Wales public sector agencies via the information protection principles.
How does that cover disclosure?
I think that comes under the fact that I think it comes under freedom of choice. I think. I'm just sort of having a quick brief overview of it now. I might have to search it separately.
Well, think about that disclosure and mandatory reporting.
I got one for Victoria.
Yep.
See, I got the Privacy and Data Protection Act 2014. So that's
Don't
for
lose these because you're
Victoria.
going to need these for your assessments as well. So can you tell me a little bit about that
Yep, that one.
legislation?
Yep. Okay, so it the personal information can include your name, email address, postal address, phone number, signature, or fingerprint. So I think we're looking on, sorry, digital, aren't we?
Yeah.
Yeah. Photos or surveillance footage of you, comments written about you, or your financial details. So be to be considered personal information, the information or opinion must be recorded. It will be considered. Sorry, it will be considered.
I also found a Public Interest Disclosure Act 2022 for New South Wales as well.
Did you find anything on the disclosure on the first act?
No, but I had to find a secondary act.
Right. And what is that covering, Tash?
Applies to all New South Wales public sectors agency. The PID Act provides a framework for public officials to report serious wrongdoing in the public sector and to be protected when they do so.
Okay. Adam,
Uh,
did you?
Oh, sorry, Anne.
You're right. Gabby?
Yeah, it's also political opinions and your membership of political association. Also, I actually don't know religion, philosophy, I can't say it, philosophical beliefs. So and membership to a trade union. It's like a whole history
Yeah.
of this. Yeah, there's a lot of information. So example, if you're filling out a form to order a new bin from your council and you are asked to provide your date of birth, you can choose not to provide this personal information.
Mm.
Yeah.
And it's interesting how many things will not let you progress unless you give this information, isn't it?
Yeah.
Yeah. Yeah. But
It's
by
like when
rights,
it's like when if you ring a hater, you immediately get you may be recorded. You were recorded. Please let the
yeah,
staff know if
which you
you did
get
not.
with all organizations, don't you?
Yeah,
Like,
pretty much.
yeah.
Yeah. So that's a little bit like one privacy, confidentiality.
Yeah, keeping that confidentiality, keeping that information. I think it's one of the biggest things that's right across the board of government organizations, but they also then have issues with leaks and people not following the protocols and causing those problems that information can get disclosed in different ways, or their record management's not following the procedures. They're not following the aspects of these laws, then, are they, to protect people's information? Adam, did you research South Australia?
Yeah, I did a little bit from what I can see. The closest that they have is the Freedom of Information Act. They don't seem to have any specific legislation for privacy and disclosure, but what they say is that the government agencies are required to comply with the information privacy principles instruction. And uh, My internet is really
Frozen.
slow, so sorry for this.
Yeah. Just frozen a little bit, Adam.
And I've lost.
Yeah, we've lost it a little bit there.
Am I back?
Yeah, you're back now. There you go.
Did you hear anything I
Yeah.
said?
We lost probably about the last two sentences. If you could give us the last little bit again, please.
Okay. What they have in place is, they say, the state government agencies are required to comply with the Information Privacy Principles Instruction, PPI, that regulates the way state government agencies can collect, use, store, and disclose personal information. That also includes the right for an individual to access and amend their own personal information via the Freedom of Information Act.
Okay. Okay. Well, there's a lot to consider, being a worker in the industry with this, in that having to know these state territory laws that you're working within, the boundaries, the limitations that we have, the legal requirements we have. There's a lot to learn, and we need to ensure that we are doing this as workers to be able to be meeting the threshold for the standards that are required in the industry to support people. So think about that. Think about making sure that you stay current when you're working in the industry, making sure that you do PDs to update with any information as well. It often can be a requirement of an organisation that happens as well. So next week we will have session 2, and we will unpack the task for this next week. So don't forget, try and get into task 1 this week and get that out of the way. There's only 2 sessions in this, so it will go quickly, and then we're on to our new module again. So please go and have a look at those tasks. We're going to unpack the second task because they're much bigger tasks. But if you can get onto the task 1 and get into that, that'd be great. All right, don't forget you can reach out for a Calendly trainer support, linking in through your Calendly access area in Accelerate, and you can email me with questions at helen@hayderinstitute.edu.au. Right, everybody have a great week and take care.